Okay, so today we'll be going for the test for the bile salts and the bile pigments. Anybody has any idea of where is this bile present?
In the liver.
In the liver. It's produced in the liver and stored in the gallbladder. Okay, and whenever the body requires, gallbladder releases it throughout the day, and it helps in what?
Digestion.
Digestion. Exactly. So here we go. So this is my topic. Rotates around this part, liver. Over here it will produce. This is the anatomical location. I think your anatomy is not covered yet in the organs, so just in a rough idea, this is how liver looks like, and this is the left lobe of the liver, right lobe of the liver, and this is the shade that you can see, that is the gallbladder. You can see that shade, and over here in the gallbladder you can see the bile is stored over here. Okay, and this is how the stomach is coming, and this duct which is coming, this is the bile duct and this is the hepatic duct, and joins and forms a common bile duct, then ultimately opens up into the second part of the duodenum. Okay, this is the duodenum. Okay, this is stomach, first part of the duodenum, second part of the duodenum, third part of the duodenum, and then fourth part. Okay, that's all in short. Now introduction. The bile salts are the sodium and the potassium salts of the taurocholate acid and the glycocholate acid. What does that mean? That there are two acids that is present in our body, that is the taurocholate acid and the glycocholate acid. Now the sodium and the potassium salts means this taurocholate acid and the glycocholate acid can be sodium taurocholate and sodium glycocholate. Same way, potassium taurocholate, potassium glycocholate. These are the sodium and the potassium salts. Basically, sodium and potassium binds with these acids and form that conjugate. That is the bile salt. The main commonest bile salt that we are getting are the sodium taurocholate and sodium glycocholate. Okay, just write it down because we won't be providing any PDF anymore. So anybody who is lacking behind, just tell me before I skip the slide. And even if I skip the slide, if there is anything pending that you haven't written, just ping me. Now their functions are what? That I already mentioned, that it helps in digestion and absorption of the fats. Okay, and are excreted in the urine in case of obstructive jaundice. Now what happens in case of obstructive jaundice is, these bile salts are easily, first try to understand, okay, rather than just copy pasting, I'll just give you the time to write it down. First try to understand what happens. These bile salts are easily diluted in the water. What happens in obstructed jaundice is, let me give you an image, you will have a better idea. Let's say this is liver, okay, and this is how the duct is coming, and this is the gallbladder which is there. Now over here there is an obstruction. Okay, now because of this obstruction, this bile cannot come here, and from the liver also it is coming and it cannot pass through. Now what happens? These are stored in the liver. Okay, and these bile salts are easily diluted in the water. So what happens? This regurgitates in the liver only. It remains in the liver, and the blood circulation that is there in the liver, which is continuing by the hepatic artery and the portal vein, these bile salts get mixed with the blood. Okay, and through the blood circulation it comes out. Okay, so that is why in case of obstructive jaundice, this increases in the urine. Once these are present in the blood will come to the kidney. Okay, kidney will not be able to filter it out, and it comes out in the urine. So that is why the concentration increases in case of obstructive jaundice. Fine. Now they are made in the liver and excreted in the bile. The same thing, they are made in the liver and then excreted in the bile. Okay. Now about 1% is excreted in the feces. So what happens? Anybody has any idea why feces looks like yellow? Why the normal color of the feces is yellow? Yeah. Which bilirubin? Stercobilinogen, yes. In case of urine, this is urobilinogen. In case of stool, it is stercobilinogen. Okay, I'll tell you the metabolism pathway, how it happens, everything will be there. But for now, just remember that stercobilin is the particle that gives the color of the stool as yellow color. Okay, so 1% of these bile salts are getting excreted, and rest of the 99% are reabsorbed in the intestine and returned to the enterohepatic circulation. Now, these things are pretty much new to you people. Anybody has any idea about this thing? How it is getting reabsorbed and how it is getting into the enterohepatic circulation? I hope not. Okay, now let me explain. Now see, let's say this is our stomach, okay, and this is the duodenum, and this the small intestine, ultimately the small intestine opens into the large intestine. This is the basic anatomy that we are getting. Just bear with my hand drawing, okay, just giving a rough idea. So this is the large intestine, ascending, transverse, descending, and then the sigmoid colon, and then the rectum. Okay, this is the rough idea you are having. So now here is our liver, okay, and here is the bile ducts. This is the gallbladder and cystic duct, common duct, and opening into this part. Okay, and over here this is the pancreas as well. This is the rough idea that you can get. Now what happens is this bile is secreted over here. Okay, normal human being, the bile is getting secreted over here. We are taking the food from here. Food is coming through here, mixing up with the biles. Pancreatic enzymes are also mixing, and then it is coming through the intestine down below. Okay, now over here in this process, from the terminal portion, there are many small veins are there, which is absorbing the nutrients from the food, which is getting digested over here in this whole process by the enzymes secreted from the pancreas as well as from the bile that is coming from the liver. Okay, it is getting digested over here and then absorbed from here. Okay, now once these veins are collecting these nutrients from the food, whatever we are taking, this will get back to liver again. Okay, for the metabolism of those nutrients. So this circulation which is happening from here, these veins are taking, then going to bigger tributaries, then larger one, then the portal vein, and then ultimately ending over here. Okay, so this circulation is known as the enterohepatic circulation. Entero means this system, hepatic means this system. So this is the enterohepatic circulation through which the bile is rotating continuously. So bile coming out from here, mixing with the food, helping in digestion, little bit 1% of it is excreted through the stool, and rest of the 99% is remaining and getting back into the liver again. Okay, fine. Anybody has any doubt in understanding this part? Okay, so that is how this enterohepatic circulation is going on, and 99% of this bile is getting reabsorbed from the intestine. Okay, in case of obstructive jaundice, what happens? This part is blocked. Let's say this duct which is coming, this is obstructed. Now the bile cannot come out through here. If the bile cannot come out through here, this bile salt specifically, not the bilirubin, okay, this bile salt is easily diluted in the water. There is one thing called water soluble and water insoluble. They are water soluble. Just because they are water soluble, they get mixed up in the liver only, inside the liver only, and they get into the hepatic circulation. Once they mix up in the hepatic circulation and comes in the blood will circulate through the kidney. So that blood, when it comes to the kidney cannot reabsorb it out, and the bile salts comes out in the urine. It can be anywhere actually. It can be a common bile duct, it can be in here also, it can be inside the hepatic as well. I just gave you an example of common bile duct. Okay, what we say because of the stone. Okay, let's say some stone is there. Okay, some stone is impacted over here. That is the gallbladder is blocked, but some little bit of bile can come out. Okay. But over here, when it is blocked, nothing can come out from here. Okay, so the amount of bile salt which will be present in the urine will be much more in case of CVD blockage rather than this block. And the same block over here, which is over here, it can be here as well, here or here. This can also be blocked. Even inside the hepatic also can be blocked. Okay, these all will be taught to you in case of medicine. These are intrahepatic blockage, these are extrahepatic blockage. Among the extrahepatic, this is close to liver, this is away from liver in the CVD. These are all variants of clinical cases. Right now you won't understand all these things. Okay, until and unless your medicine is getting covered, these things are literally beyond the league. So for now, just remember, if the bile tract through which the bile is coming out to the intestine, if that is blocked, that means obstructive jaundice is there. Okay, everybody fine? Okay, next. Now the hair sulfur test. It's a very simple test that we are doing, but rather than doing the test, there are many catches during the test. When you will be doing, there are many catches. First of all, let's just understand what is the test about. Okay, again follow, see here. Okay, everybody see here. Everybody see here, we will take two test tubes. Okay, till now whatever test we were doing in one test tube. We are taking the urine sample and we are doing the test, and whatever the results are coming, depending upon that we are coming to the conclusion, right? We are not using any control till now. So over here we will take two test tubes. Okay, in one test tube we will take distilled water. Okay, in another test tube we will take urine sample. Fine. Now how much to fill it up? Here is one question, how much to fill it up? You have to fill up 3/4 of the test tube. Now there is a catch, why 3/4? Okay, I'll come to that. Now you have taken 3/4 of distilled water, 3/4 of urine sample, and you will add pinch of sulfur. Okay, here also pinch of sulfur, here also pinch of sulfur. If the sulfur remains floating in the surface, that means there is no bile salt in the sample. And if there is bile salt in the sample, as soon as you put the sulfur, the pulse sulfur will precipitate at the bottom of the test tube. Okay, so that's the simple test. There is nothing more than that. You just have to see if the sulfur is settling down or not. Okay, depending upon that, you can come to the conclusion whether the bile salt is present or not. Now the things what is coming to the question are, why we are using distilled water. Okay, now if we take the urine sample and if we put the sulfur into it, if it precipitates, then the sulfur is present. If it doesn't precipitate, then the salt is not there. Okay, but why we are using distilled water? What is the point of using this reference? What happens is, that sulfur powder we are using, sometimes the sulfur powder can be with moisture. Okay, sulfur powder is not dry enough. Probably you did not store it properly, or probably somewhere or other it got some moisture from the weather. The lid was not closed properly. Okay, because of the storage malfunction, the sulfur became little moisture. Okay, and because of that moisture, what happens in distilled water also, if you add that moistured sulfur, that will also precipitate. So this is to rule out, this control we are using to rule out if the sulfur is perfect or not. The sulfur that we are using, whether it is moisture free or not, to rule out that is why we are using the distilled water. Understandable? We are not using the distilled water to rule out, to compare with the urine. We are using the distilled water to rule out if the product that I am using, the sulfur that I am using, that is perfect or not. Okay? If that sulfur is settling at the bottom of the test tube, that means that sulfur is not good enough. Okay, we have to take a dried up sulfur. Now another question is, why 3/4? I can do that much with this much urine as well. This will precipitate over here, and I can do the distilled water this much as well. Why 3/4? Okay, 3/4 why? Because if I put sulfur from here, if I put my sulfur from here, because of the gravity, sulfur will fall. Over here also, if I put my sulfur, because of gravity, sulfur will settle down at the bottom. So that will give me a false result. Okay, so I'll think like my sulfur is false, my sulfur is wrong, my sulfur is not working properly, that's why it is settling below. But you are doing the test wrong, because of this much space in the test tube, whenever you are throwing it from above, it will fall and immediately go to the bottom. Okay, so these are some certain things that you have to remember. Now you cannot use much amount of sulfur. You have to use a little bit, pinch, as little as possible. Okay, you have to add the sulfur. Why as little as? Because if you add more sulfur, because of the mass of the sulfur, it will again fall. Okay, so the test is very simple, but questions are multiple from here. Okay, why you have to add pinch of sulfur, why 3/4 of the test tube is filled up, why this distilled water is used as a control. Okay, now see over here what is written. The bile salts reduce the surface tension of the urine. Now anybody has any idea about surface tension? What is surface tension? What is surface tension?
Tendency of water molecules to maintain a level.
No, not maintain a level. The tendency of any liquid to push something above it, not to settle it down, not to fall through it. Okay, the same way you can see some water insects are floating in the water because of the surface tension of the water, they don't sink below. So any property, the property of water or any liquid to push something up above it rather than sinking it down, that is known as the surface tension. So the normal surface tension of the urine will not allow this sulfur to fall. But whenever this urine sample contains bile salts reduces the surface tension. So the ability of keeping the sulfur up in the fluid is decreased in the urine sample when it contains the bile salts. So in that case, as soon as you add the sulfur, just because the surface tension is low, it will fall. Okay, so that is what is written over here. When the bile salts reduce the surface tension of the urine, which can be detected by sinking of the sulfur powder in the urine. Now what are the two common bile salts that we come across? That is the sodium taurocholate and the sodium glycocholate that I have already mentioned. This can be potassium as well, this can be sodium as well. The commonest one, that's why I gave two examples of the sodium. Now procedure, take two test tubes, fill 3/4 of each of the test tube with distilled water and urine respectively. and sprinkle small amount of finely powdered sulfur on the surface of the distilled water as well as the urine in the both the test tube. I have already mentioned, people can write it down now. Yeah. That is what I said. If you keep it over here, this space is less, right? So as soon as you add the sulfur, it will float over here. But if the space, if let's say you have filled 1/4 of the test tube, now you are throwing the sulfur from here. As soon as you throw it from here, because of the gravity, it will come with a much more velocity and it will sink below. Because the it is water only. It just have to keep the sulfur above. Okay. So if the gravity, it gets that fraction of the gravity, it will just sink below and it will give you a false result. That is why we are using the 3/4 of the test tube. Okay. Everybody wrote it down? Once you are finished, just let me know. Because in normal water, there will be some particles or molecules present in the water. In distilled water, there is nothing other than the H2O. Okay, so that is the purest form. As soon as there are some impurities in the water, these will affect the surface tension of the water. So in case of normal water, if I use the tap water, this will be more. This will have more impurities and the surface tension will be reduced. If the surface tension is reduced, it will again fall. Because of the mass. If the mass of the sulfur powder is more, it will again sink. So that's why you have to just sprinkle little bit of sulfur, whether it floats or it sinks. That's all. Now, these are the observation and the precaution. Observation is what? Sulfur powder sinks rapidly in the urine containing the bile salts, but do not sink in the test tubes containing the distilled water. I have already explained why. You all know. Okay, now precaution, do not shake the test tube, let them stand for few minutes, otherwise false results are produced. Now, there is one more thing, as soon as you add the sulfur, don't mix it. If you mix it, it will fall eventually. Okay, so don't you mix it. Just take the test tube, add the sulfur, if necessary, put the test tube in the stand and then you add the sulfur and just see by the side whether it is falling or not. That's all. Okay. Do not use excess sulfur, otherwise it will settle due to its mass. Your question, why it was a sprinkle. Fine. Now use the fresh sulfur so that it is moisture free. That is why we are using the distilled water as a control, so that we can see if the sulfur is moisture free or it contains moisture. Okay. There is one note that you have to make, like urine preservative, that in my first class I told, like we can use some urine preservative like thymol, chloroform, something. So this thymol can also give false test if it is already there in the urine. So whenever you are doing the H sulfur test, do not preserve it with thymol. Okay, take the urine sample, keep it separated. You can preserve it with some other products, but not with thymol. If you add thymol, it will give you the false result.
Don't you know the precautions?
Pardon?
Precautions.
Yeah, you can write it down. If you think like, yeah, you can remember, then you skip it. It's fine. No, not in practical copies. These are for your question purposes. In your practical copy, you have to write what is the principle, what is the procedure that you are following, what is the observation you are getting, and what is the inference that you are coming into. That's all. Precautions you don't have to write in the practical copy. In your
Clinical interpretations.
No, not the clinical interpretations also. These are only for your understanding, so that you can correlate the things. That is why we say whatever slides we are presenting over here, or whatever things we are teaching you, everything should not be written in the practical copy. Practical copy is for whatever test you are doing. The clinical reference that we are giving you, so that it can help you in understanding more. So that you have a better clarity why we are doing the test, what is the need of this test. Ultimately, behind everything the question should be there, why you are doing it. If you don't know why you are doing it, then what is the point of doing it? Just because we are telling you to do it, you will do it, that doesn't make sense. You have to know why you are doing it, the reason behind it. That is why we give the clinical correlation as well as these extra precautions, whatever is written over there, that this kind of questions may be asked. Okay, in the Viva, examiner will ask you why you are not using 2 grams of sulfur, why you are just sprinkling the sulfur, why you are using filling up 3/4 of the test tube. I can do it with the half filled test tube as well. Why you are not doing it? Okay, so this kind of questions can be asked. That's why I thought of putting these things. Okay, that's all. Everybody done with writing? So see, over here there is one image as well. See, in the distilled water you have added some sulfur and it is somewhere up to this much. Okay, it did not go at the bottom, but over here you can see that this has settled at the bottom of the test tube. Done? Okay. Now clinical significance. Now they get regurgitated into the systemic circulation in the hepatic and the post-hepatic jaundice because of intra and extrahepatic biliary obstruction. Now you remember the thing that I have already made, shown you with the drawing. In the intra and the extrahepatic obstruction, what happens? If these things are getting blocked, whether in the bile duct or in the close to the liver, inside the liver or just outside the liver, it doesn't matter wherever the block is. Because of those obstruction, what happens? The bile is getting regurgitated. Regurgitated means inside the liver. It cannot come out from the liver. It is getting back into the liver, and then it is getting mixed into the systemic circulation. Once it gets mixed into the systemic circulation, they are water soluble and then get excreted out in the urine. The same thing is written over here that I have already explained with the photo. Fine. Now they are absent in urine in hemolytic jaundice. Why they are absent in hemolytic jaundice? Can anybody tell me? Break the words. What is the meaning of lytic? Lytic means breaking down. Okay, and hemo means blood. So basically what happens, how bilirubin is produced? When the in blood there is RBCs. RBC contains hemoglobin. Okay, right? Now this hemoglobin breaks down. Once the hemoglobin breaks down, it forms, one is the heme particle, another is the globin particle. Okay. Now from this heme, it will first convert into biliverdin. Okay, biliverdin. Then the biliverdin will convert into bilirubin. Okay. So here there is no point of obstruction. It is completely because of RBCs, then hemoglobin breaking down, forming heme, then biliverdin, and then bilirubin. There is no point of obstruction. So that's why these are absent in the hemolytic jaundice. So the pathology is different. That's why we will not get the bile salts in case of hemolytic jaundice. But in case of hepatic jaundice, they are present in the urine. Why in the hepatic jaundice they are present? Now in the hepatic jaundice, what is happening? Here is the liver. Okay. Some pathology is there. Let's say liver cirrhosis is there. The patient is chronic alcoholic. Because of alcoholism, the livers, these hepatic tissues are getting dead and it is not properly functioning. It cannot reabsorb the bile over there and some amount of bile is coming out. Okay, so because of that, some amount of bile salts can be present. But what happens in case of obstructive jaundice is it is completely obstructed. Nothing can come out from the liver. When nothing can come out of the liver, it will get regurgitated back into the system, and then this will be excess in the urine. So that is why three different conditions that I have shown. One, in case of hemolytic jaundice, there will be completely absence of the bile salt because the pathology is different. Okay, now this thing will be again necessary for the bile pigments. I'll explain again. So in case of hemolytic jaundice, hemoglobin is breaking down, forming heme and globin. From the heme, it is forming biliverdin and ultimately forming the bilirubin. Okay, so because of that, there is no chance of bile salts coming out in the circulation. The pathology is completely separate, and because of that, the patient is having jaundice. Now, what is jaundice? Excess amount of bilirubin in the circulation and giving the yellowish discoloration of the skin, sclera and all these things. Okay, fine. Now in case of hemolytic jaundice, the jaundice will be there but the pathology is different. That's why it is not because of the bile salts, and the bile salts in the urine will be normal. In case of hepatic jaundice, some pathology is there but it is in the liver. Some amount of bile is coming out. Okay, so in hepatic jaundice, some amount of bile is coming out from the liver and some is not being able to come out because of the pathology in the liver, and because of that some amount of bile salt will be present in the urine. But in case of obstructive jaundice, there is complete obstruction of the tract. No bile can come out through that tract. And in case of complete obstruction, there can be partial obstruction, there can be complete obstruction. In partial obstruction, the amount will be little less, but in case of complete obstruction, the amount will be more. Now, what is partial complete obstruction? The same thing. This is the tract and this is the gallbladder. Let's say if this much is obstructed, okay, some stone has there, some stone is there, like we commonly say the gallbladder stone. Gallbladder stone can be there. Okay. Now some of the gallbladder stone lodged out from here and blocked this part. Okay. Now some bit of bile can trickle down over here. Okay. So the amount of bile salt will be high as compared to normal, but not too much. But if it's a complete obstruction, let's say over here there are two stones which is completely blocking this part. Now nothing can come out from here. In that case, it will be excess level of bile salt that is present in the urine. Okay. Now this test why we are using, basically to find the liver function, if the liver is functioning properly, if the biles are getting reabsorbed properly or not. Okay. Everybody done with writing? Okay, please write it down. Yeah. In case of hemolytic jaundice, what is happening? Basically, jaundice is what? Increased level of bilirubin. Okay, and in case of hepatic jaundice also there will be increased level of bilirubin, but both the conditions, the pathologies are different. In case of hemolytic, basically blood is getting broken down. We know what RBC's lifespan is how much? 120 days. After 120 days, what will happen? The RBC will get destroyed. Once the RBC is getting destroyed, where will it get destroyed? In the reticuloendothelial system, in the RES, reticuloendothelial system. This is the system which is throwing out the foreign bodies, all the unwanted substances from our blood, from our body. So reticuloendothelial system, over there the RBCs are getting lysed, releasing the hemoglobin. Then the hemoglobins are getting lysed and forming, one is heme, another one is globin. Understandable? So from the heme it is forming the biliverdin. Hepatic jaundice. In case of hepatic jaundice, what is there? In the pathology is in the liver. Over here there is no pathology in the liver. That is why this will be completely absent in this case. Is there any concept of bile salt over here? No. So that's why there is no bile salts in the urine. Fine. In case of hepatic jaundice, what is happening? Some pathology in the liver. Liver is doing what? Reabsorbing the bile salt and again metabolizing it. Now the liver is damaged. Liver is having cirrhosis. Because of chronic alcoholic patient, the liver is having cirrhosis or you can say chronic liver disease. Okay. If the liver is not functioning properly, it will not reabsorb the bile salt properly. It will not reabsorb and the bile salt will come out again in the urine.
Sir, bile salts और pigments दोनों duodenum से तो reabsorb होते हैं।
अरे बाबा, bile salts duodenum से निकल के आ रहे, intestine में जा रहे, वहाँ से reabsorb होके तो फिर से liver में ही आएगा ना. Liver is not taking up it. Liver cells or hepatocytes are not working. If the hepatocytes are not working, then how will it reabsorb? Did you get my point? If the hepatocytes are, let's say तुम्हारा काम है कि बाइल को छोड़ना और जब बाइल घूम के आए दोबारा फिर से इसको कैच कर लेना. अभी तुम ही नहीं हो, तुम्हारा काम ही नहीं है वहां पे, तो फिर बाइल को कैच कौन करेगा? वो तो फ्रीली निकल जाएगा ना. समझ रहे हो? बाइल सॉल्ट भी होता है, बिलिरुबिन भी होता है, दोनों होते हैं. Now we are talking only about bile salts. That's why I am talking about bile salts. When I'll come to bile pigments, again bilirubin. This is not about bile pigment actually. This is about bile salt. Bile pigment will be next one. That time you will understand everything. How is it coming? Fine. Now this is where the bile pigment comes. Okay. The most commonest bile pigments are the bilirubin and the biliverdin. Okay. Now this is how the metabolism of bilirubin and this is how the bilirubin is coming out. Okay. Now see, try to find it over here. Now in the reticuloendothelial system, what happens? RBC is broken down and forms the heme. From heme we are getting the unconjugated bilirubin. Okay. Now there is two form of bilirubin. One is unconjugated, another one is the conjugated. Conjugated bilirubin means it mixes up with the albumin that is present in our body. Once it mixes up with the albumin, it is easily transportable. So because to make it easily transportable, it binds up with the albumin in the bloodstream and then forms what? Unconjugated bilirubin albumin complex. This is also known as the indirect bilirubin. Like if you have ever seen any blood report of any LFT finding, you can see there are two types of bilirubin written over there. One is indirect bilirubin, another one is the direct bilirubin. Okay. Indirect bilirubin means this is the bound form of the bilirubin, and direct bilirubin means this is the free form of the bilirubin. Okay. Now once it is bound form with the albumin, this is known as the indirect bilirubin, which is easily transportable, and in the liver it goes, then reacts with the enzyme that is the uridine glucuronide transferase, and with that it gets converted into the conjugated bilirubin, which is also known as the direct bilirubin. Now this direct bilirubin will come to the gut. From the liver, same pathway, after getting secreted it will come to the gut. Okay. Once it comes to the gut, now your thing was what in case of hepatic jaundice. If the liver cells are destroyed, this bilirubin should also go back. Again, this urobilinogen which is coming in the gut, again it will go back to the via the enterohepatic circulation. This bilirubin will also go back. Like the bile salts are going, the bilirubin will also go back with the same circulation. Okay. So once it is going back, the liver have to reabsorb it and need to metabolize it and keep it stored. Now bilirubin as well. Okay. So that is why when the bilirubin is coming into the gut bacteria will make it urobilinogen. That is what is there in the gut. Now this urobilinogen divides into three portions. One is 80% of will get secreted in the feces as the stercobilin, which will give the stool yellow color. 2% of will get secreted in the urine, that is the urobilin. Okay, and rest of the 18% via the enterohepatic circulation goes back to the liver again. Okay, in the liver, see, in the liver, that is that conjugated bilirubin that is getting stored. Okay, liver is releasing that conjugated bilirubin and getting stored in the gallbladder. Whenever body requires it, the gallbladder releases it, and sometimes liver also directly releases it. Now if the liver is damaged, this pathway will not take place. Over here, after going here, it will not take place. So what happens, this will not go back here, it will be there in this circulation only gut, and that is why the body will try to reabsorb the bilirubin, and in the blood also the bilirubin will also be raised, and that symptoms will also be there. In the LFT finding in the blood, you can get the symptoms, as well as in the urine finding as well, you can get the symptoms. Now there is a catch. In case of, let's say there is an obstruction, let's say there is an obstructive jaundice, do you think that excreted bilirubin that is there in the urine, it will be there? If there is an obstruction, again going back to the same concept, little confusing, but try to understand. Let's say here is the obstruction. Okay, now the bile is not coming down. Do you think there will be urobilin present in the urine? What do you think? Tell me. मैं तो बिलिरुबिन का बात कर रहा हूँ, मैं बाइल सॉल्ट का नहीं बोल रहा. दैट इज व्हाई आई आस्क्ड. बाइल सॉल्ट तो रीअब्जॉर्ब होकर यूरिन में आ रहा है, लेकिन बिलिरुबिन तो नहीं जा रहा है. बिलिरुबिन इज नॉट वाटर सोल्यूबल. तो फिर आना चाहिए या नहीं आना चाहिए, क्या बोलता है बेसिक सेंस, क्या बोलता है? व्हाट इज योर बेसिक सेंस? नहीं आएगा. बेसिकली इट विल नॉट कम. if the bile duct is obstructed, the bile will not come to the gut. If the bile is not coming to the gut, if the bilirubin is not there, obviously these steps will not take place. It is not coming out from here only. Liver से तो निकल के आना पड़ेगा ना. If it is not coming out from the liver, obviously these steps will not happen. If this step is not taking place by the gut bacteria, this bile will not be there. This urobilin will not be there. So the pale color stool that we find in case of any liver patient in obstructed jaundice, we get pale color stool, and the urine is also not yellow, it is whitish. Why? Because of the absence of the urobilin, the urine will be little whitish, not the pale yellow color that it should have normally. In the same way, the stool that should have been yellowish, it will not be yellowish, it will be clay colored. Anybody seen clay? Anybody who is painting and making things, the clay, little ash color thing, the stool will also look like ash color. That is the clinical description the patient will say. Once the patient is coming and saying like, sir, my stool is clay colored, it's sticky and it's clay colored, that means it is suggestive of some obstruction is there in the bile duct. Because of that, the bilirubin is not coming down and these steps are not taking place. That is why these are also not there. The stool is pale colored, urine is also pale colored, and enterohepatic circulation का तो सवाल ही पैदा नहीं होता. ठीक है? This all will be taught to you in pathology actually. This is the pathology part. I am teaching you so that you can understand what is actually happening. Otherwise, I can just write it down that bilirubin is absent in complete obstruction. Bilirubin will not be there in the urine. But why? Why it will not be there? That you should understand, because these steps are not taking place. So little difficult it could sound, but if you go through once or twice, you will definitely understand. Nothing rocket science over here. Very simple thing. Everybody done with it? This is the unconjugated bilirubin after mixing with the albumin also. This is easily transportable. That's all. This is for the purpose of transportation. Once it is easily transportable, it goes into the liver. Then it will react with this enzyme, and this enzyme will make it conjugated. Hmm. Urobilinogen via the enterohepatic. Yeah, via the enterohepatic circulation, the same circulation that I have drawn from the lower portion of the intestine, it will go back to the liver again. Enterohepatic circulation from the enteric part to the hepatic part. The same way bile salts are getting reabsorbed, the same way the bilirubin will also get reabsorbed. Same pathway. Same pathway. Fine, everybody done? Okay. Okay, now which test we can do for the bile pigments? The Faucher test. Okay. I'll just show you a demo of the Faucher test. You people won't have to perform the Faucher test either in exam nor over here right now. Just give you a demo how these tests are done. Okay. You don't have to perform it in the lab. I'll just show you over here, all the reagents are there. In practical book also you don't have to write it down, because yeah. Pardon? Absence of stercobilin. Urobilinogen will divide into three parts. One is forming the stercobilin, another one is the urobilin, another one is as it is coming via the enterohepatic circulation. The stercobilin is responsible for the yellow color of the stool. In case of obstructive jaundice, it will not be there. Stercobilin will not be there, so that it will be pale color stool. Okay. Now, please be silent. Faucher test. What is the principle of the Faucher test? Some barium chloride is there. One of the reagent is the barium chloride that we are using, which is reacting with the sulfate radicals in the urine to form the barium sulfate. Now, bilirubin, if present, it adheres to the precipitate and is detected by oxidation of the bilirubin, that is yellow color, into biliverdin, that is green color, with the perichloride in presence of the trichloroacetic acid. Now I know you people did not understand anything from this line, so let me just break it up. Okay. So these are the bookish languages, that is how it is written. So over here I am using one reagent, that is the Faucher reagent. Okay. First of all, write it down, the Faucher reagent. Okay. What is the Faucher reagent contains? Faucher reagent contains two things. One is perichloride. Another one is the trichloroacetic acid. Okay. These two are the Faucher reagent. Okay. Now what is happening? There is barium chloride, one more reagent we are using. Barium chloride is doing what? Let's say this is a test tube and these are the urine sample. Okay. Now over here we are using what? First putting the barium chloride, BaCl2. We are using the barium chloride. Once we are adding it, it is mixing up with the sulfate particles in the urine and forming what? Barium sulfate. Okay. Once it is forming the barium sulfate, we are mixing glacial acetic acid with it. We can either use glacial acetic acid, we can use magnesium sulfate, whatever we have, we can use. Once we are mixing glacial acetic acid, what it does is, it reacts with this thing, and along with this part, there are the bile pigment, that is the bilirubin is there. We are suspecting some bilirubin is there, for that only we are doing this test. So that bilirubin will also precipitate at the test tube, at the bottom of the test tube. Okay, everything settles down at the bottom. So that for that reason we are adding the barium chloride. First it reacts with the sulfur particle, forms the barium sulfate. Then we are adding glacial acetic acid, and everything settles down at the bottom of the test tube. Okay, at the bottom of the test tube, let's say this is the urine sample. Now this is the urine and these are the precipitate. Okay, now it will take some time to settle down. We are not waiting for that time to settle, for all this particles to settle down. This will be little cloudy. You can see that cloud is there. It will gradually settle down. Once we get that cloudy solution, now we will take what? We will take a conical flask. Okay. Now over here we will add a filter paper into it. Over there you can see over here you can see, right? This conical flask is there. This flask is there, okay, and there is one filter paper into it, okay. Now we will put this solution that we got, we will put it through here, and the cleared fluid will fall below, and the thick substance that was precipitated, it will be there in the filter paper. Once it is there in the filter paper, we will do what? We are suspecting this yellow color bilirubin is there. That is why this substance which is there in the filter paper, it will be yellowish in color, little yellowish. We are suspecting some bilirubin is there. Now as soon as we are using this Faucher reagent into this bilirubin, this will turn green colored. That is the presence of biliverdin. Why? This bilirubin is getting denaturated into biliverdin by this Faucher reagent. Okay, so this color change will confirm us that bilirubin is present in here. If the color change is not happening, that means it was not bilirubin only, because Faucher reagent will break down the bilirubin and form the biliverdin. Okay, so if the after adding the Faucher reagent there is no color change, that means bilirubin is not there, and if changes the color, bilirubin is there. So the principle whatever was written over there, see, barium chloride reacts with the sulfate radicals which was reacting over here in the urine and forms the barium sulfate. Form the barium sulfate. If bilirubin is present, adheres to the precipitate. If bilirubin is present into it, as soon as I add the glacial acetic acid, it will form the precipitate at the bottom of the test tube or in the solution. Once we get there, it is detected by the oxidation of the bilirubin. Oxidation is done by what? Oxidation is done by the Faucher reagent. Faucher reagent is causing the oxidation of the bilirubin that we are suspecting. Now this yellow color bilirubin will turn into green color biliverdin because of the oxidation done by the Faucher reagent. Okay. And Faucher reagent contains what? Ferric chloride and trichloroacetic acid. That is what is mentioned over there. Ferric chloride in presence of the trichloroacetic acid. So, anyone has any doubt in understanding these steps in the principle? Anybody has any doubt? Okay, I hope no. Please write it down if you feel like and let me know. Not necessary, not mandatory. They don't ask that much. No. They might, as much as they might ask you what are the constituents of the Faucher reagent or what are the steps basically, not the principle proper. Nobody is going to ask you the principle of the Faucher test. Unless and until the examiner is very strict, then they might ask. Bad luck. Somebody has any grudge on you, then they can ask. I don't know. So that is fun apart, but yeah, not usually asked. Okay, but you just have to know the reagents of the Faucher, what are the constituents of the Faucher reagent and how it is working. Basically, if you know this much part, whatever I have told you in the own language, you can at least explain what is happening in the test. Once you know what is happening in the test, examiners are fine. Yeah. Please write it down. Yeah. What is HCl? Acid. Glacial acidic is also an acid. That's all. We are adding it for the precipitation of the bile pigments. Bilirubin. If the bilirubin is there, it will accumulate the bilirubin and it will form the pigmentation. It will just settle it down. It's just a chemical, nothing else. There is nothing to know what is glacial acetic acid. The way HCl is an acid, the way nitric acid is an acid, glacial acetic acid is also an acid. It's a chemical reagent. We are using. You can ask why we are using it. What is the purpose of using it? That is a question. That question is to settle that precipitate down. Okay, so that the bilirubin, if there is any bilirubin, it precipitates down with that. It is not circulating in the fluid, just precipitates with the barium sulfate. Fine? Yeah. Done? Done with writing? Okay. Now, this is the reagent. Faucher reagent contains what? Ferric chloride and trichloroacetic acid. You can see the bottom over here as well. I don't think so. This is Faucher. This is glacial acetic acid. Okay. Now, and another one is the barium chloride. These two are the things that we require. And glacial acetic acid or magnesium sulfate, I did not add over here because you can use any of it. Either you can use magnesium sulfate, either you can use glacial acetic acid. The purpose is to settle down the bilirubin if there is anything in the circulation. That's all. Now, the procedures. Take 5 ml of urine, add 2 drops of the glacial acetic acid into it, 5 ml of barium chloride, and the pigments are precipitated along with the barium sulfate. Whatever I have already explained, the same thing is written over here. Now filter it out and spread the filter paper on a porcelain tile. Porcelain tile means the down below whatever you are keeping that thing should be clean, that should be white, so that you can see the color change. If that color is already green, whatever is you are using, that color is already green, then you can see like, oh sir, this is already green beforehand only. No. So that is why the down below whatever you are using, that should be clean enough so that you can see the proper color of the precipitate which is there in the filter paper. The precipitate should be yellow in color. As soon as you add the Faucher reagent into it, this will turn into green color. If it turns into green color, it confirms the presence of the bilirubin into it or the bile pigments. Fine? Okay. So these are the steps you can see. This is just an animated version. This is the filter paper. Over here you are adding the solution, and the clear feed comes bottom, and the precipitate is there in the filter paper. Then you take the filter paper, spread the filter paper widely. This is the yellowish color you can see. That is where we are suspecting the bilirubin is there, and as soon as we add the Faucher reagent into it, it will turn into this green color, some greenish color tinge you can see. That is the presence of the bilirubin. Now let me do the test for you till that time. You people write it down. This is the urine sample. Okay. This is the barium chloride I have added into it. Okay, fine. Now I will add what? Glacial acetic acid. See? You can see the change. Before that it was clean. Right now it is precipitating everything at the bottom. Okay. So that for that reason we are using the glacial acetic acid. Now I can let it settle down, or I can just put it in the filter paper. Let's just settle it down for some time. After that I will do what? I will put it in the filter paper. Okay. Okay. Let it settle down. Do not concentrate into it, concentrate into the topic proper. Okay, now there is one more process we can estimate the bilirubin. Now recent days we are using all these dry chemistries and all. You all know what is dry chemistry, where we are not using any dry chemicals. We are using the dry reagents into the strips, which is reacting with the particles that we are searching for. Once it reacts with the particle, it gives the color change, and depending upon the color change we come to the conclusion which part that particle is present in the solution or not, and how much concentration we can have an approximation idea. Over here also same thing. For bilirubin we are using the strips. Now let's say if it is negative, this will remain as yellow as it is. If it is present, it can go into pink or multiple shades of pink. Okay, it can be +1, +2 and +3 depending upon the grades. Now what is important is, this is the chemical that we are using in the strips. Okay, the strips are coated with 2,4-dichloroaniline. Okay, the strip that we are using to estimate the bilirubin, that is coated with 2,4-dichloroaniline. Once it reacts with the bilirubin in the acidic medium, it forms azobilirubin. This azobilirubin is the thing that gives these colors. Okay, so this azobilirubin is the only particle that giving you the color, and this is the chemical that is there in the strip. This can be asked, that what is the chemical that is being used in the strips that is giving you the color change, with what the bilirubin is reacting. Okay, fine. Now with this test, there is a drawback of this test is you can only estimate the direct bilirubin. You cannot estimate the indirect bilirubin. Once this bilirubin is conjugated, you know where is it getting conjugated? In the liver. Once it gets conjugated, then only you can estimate this bilirubin. Before that, this test cannot estimate the bilirubin. Okay, so that is a drawback of this test. Okay, it's written over here, only measure the direct bilirubin, will not pick up the indirect bilirubin. Fine. Now, condition where bilirubin is present in the blood circulation, that is known as the hyperbilirubinemia. Ma'am has told you what is the, how to understand this terminology. Emia means present in the blood, urea means present in the urine. Same concept over here as well. If the bilirubin is present in the blood, that is known as the bilirubinemia, and if it is present in the urine, that is known as the bilirubinuria. Now, what are the conditions where you can get the bilirubin in urine? Okay, because we are not talking about bilirubinemia right now. Obstructive jaundice one, another, any liver disease. Okay, any liver disease. Liver cirrhosis is an example. It can be liver disease as well. Okay, like acute liver disease, autoimmune liver disease. There are many liver diseases. So in general, for now, just remember any liver disease, liver cirrhosis specifically, obstructed, some drug can also cause. Drugs like some NSAIDs like acetaminophen, some examples are there. This can also affect and cause damage to the liver. Basically, any drug that is causing damage to the liver. If the hepatocytes are getting damaged, that will also cause in bilirubinuria. Okay, so these are the causes of the bilirubinuria: liver disease, liver cirrhosis, hepatitis. Anybody has any idea what is hepatitis? Inflammation of the hepatocytes. Itis means inflammation. Okay, not only full Java. Okay, inflammation has 5 steps. It can be calor, dolor, rubor, pallor. That you will know in pathology. That is what I was telling. There are 5 signs of inflammation. Okay, there will be calor, dolor. Calor means rise in temperature. Dolor means pallor means rubor. Okay, these are pathology things actually. Rubor means redness, increase in temperature, localized swelling. Okay, these are all the symptoms, that all the findings of the inflammation that you can get. Okay, so hepatitis means basically inflammation of the hepatocytes. Okay, it can be because of viral infection, it can be because of any other drugs, or it can be because of any other pathology as well. Doesn't matter whatever the reason is, but hepatitis in general means the inflammation of the hepatocytes. Okay, that can also lead to the same condition, that is the bilirubinuria. Now this is how that obstructed bile duct will look like. Let's say over here this is not a stone. Okay, this is the periductal region. Okay, it can be because of that thickness that I was showing. Let's say this is the second part of the duodenum and this is the pancreas. Okay, and this is how the bile duct is opening over here. Okay, now let's say there is a cancer over here, some cancerous tissue is there. Okay, then it will compress this bile duct. Okay, there is no stone, it's a cancer over here, it is compressing the bile duct, and because of this compression the biles are not being able to come out. That is also a cause of obstructed liver. So this is one example over here in the photo that you can see. This is the bile duct that is coming up, this is the gallbladder from which it is coming, but over here this is obstructed. Okay, it cannot come out through here, it is obstructed. And this is the cirrhotic liver. You were asking what happens in the liver. See the normal liver how it looks, and now see how the cirrhotic liver looks like. Okay, this has completely been damaged. Most common cause of cirrhotic liver is alcohol. Okay, so because of that this can happen, and the liver cells are not there, it is not functioning properly, then obviously it will lead into jaundice. Fatty liver is the accumulation of the excess fat in the liver. It can happen because of taking excess amount of fatty foods which is not getting metabolized in your body, like mainly in case of junk foods if you are taking. Consequences can be these things, same cirrhosis liver in a prolonged stage. Fatty liver has grades, fatty liver stage 1, stage 2, stage 3, stage 4. Okay, in the stage 4 it will also resemble like cirrhotic liver only. It will completely fail. Let's say one hepatocyte is there. I'm just giving you a rough example. One hepatocyte is there. Okay, this is the hepatocyte as there. Now in between that there are fat particles. Okay, because of that the cells are not being able to work properly. So it will try to compensate up to a limit. grade 1, grade 2, and after that it will leave, and it will result in cirrhosis only. Okay, so grade 1 everybody of us almost having, most likely, because of our sedentary lifestyle and food habits. Okay, not cirrhotic liver, fatty liver grade 1. Okay, we don't have cirrhosis. Okay, I don't know about others, but I don't have. Okay, so fatty liver grade 1 everybody can have, and that is not a disease per se, that we can have because of our dietary habits. If somebody is having very healthy diet from the childhood that nobody is doing, so everybody has the stage 1 fatty liver can have. Okay, fine. Okay, jokes apart, done. Okay, next, test for urobilinogen. Now this part you people don't have to, we won't be doing the test also, and you people will not be doing in the lab also, just for the theoretical purpose. What is urobilinogen? Nah, that is urobilin. Urobilinogen which is there in the gut. The urobilinogen will convert into stercobilin and urobilin. Remember? Okay. Now test for urobilinogen is, urobilinogen gives the pink color. Why we are not doing it? See, it's so difficult. Urobilinogen gives pink color with the para-dimethyl aminobenzaldehyde in an acidic medium. Normally fresh voided urine gives a pink color. Now the procedure is very easy. Take 5 ml of urine, add 5 ml of Ehrlich reagent into it and wait for 10 minutes. And then add 10 ml of saturated sodium acetate solution. Development of pink color which darkens on adding the sodium acetate indicates the presence of urobilinogen. That's all. Basically you have to take a sample of urine, you have to add Ehrlich reagent into it, and then you have to add sodium acetate into it. If it will first turn into pink color, then ultimately turn into darker colors. So in simple words, these are the three lines you have to remember. First take urine sample, add Ehrlich reagent, add sodium acetate. First it will be pink in color, then it will darken. If that sequence follows up, then urobilinogen is present. Normally urobilinogen will be present or absent. In normal condition, present, obviously, otherwise how the color will come. Okay, but if it is excess, then some pathologies are there. It can be in the hepatic jaundice, or it can be post-hepatic obstruction, partial. In case of complete obstruction, completely absence of the urobilinogen. That's all. So clinical interpretation are there. Urobilinogen is increased in urine in hemolytic and hepatic jaundice. It is absent in case of obstructive jaundice. If it is a complete obstruction, then it will be completely absent. If it is a partial obstruction, some bit of urobilinogen can be there. Okay, but if it is a complete obstruction, it will be completely absent. Now the pink color, there is a catch that not only urobilinogen, porphobilinogen also can give the test positive. Now what is porphobilinogen? Porphobilinogen is not necessary right now. This will be necessary in the medicine. Porphyria is a condition, medical condition, in which the concentration of the porphobilinogen is high in our body. That can also give this test positive. Okay, just for a question purpose it can be asked, otherwise not necessary per se. Yeah. Okay, now to my test. Did anybody notice that I did not add glacial acetic acid into it? Anybody notice? See, glacial acetic acid is over here. I did not add the glacial acetic acid. What did I add over here? What is this? Huh? Barium chloride is this one. Clear. This is barium chloride. This is clear. This is the urine sample. What was necessary for me? Why I was using glacial acetic acid? To precipitate it. Did it precipitate completely? It became little turbid, but it did not precipitate. Okay. So what is this? What is the remaining one? No. Magnesium sulfate or glacial acetic acid. This is the two things that I was using. What is it? Poche reagent. Otherwise, how the test will come? Now I will show you the color of the filter paper. See the color of the filter paper. Is it yellow or is it green? Why is it green? Because of the presence of bilirubin. I did not add the glacial acetic acid. I just directly did the test. Okay. Okay. Now question answer session. Okay. In haze sulfur test, why 3/4 of the test tube is filled up? You say. Wait. Yeah, you say. Say it properly. हिंदी में बोल दो. We are having difficulties. Why we are filling up 3/4? तो अगर मैं 3/4 करूँ तो shrink नहीं करेगा. तो अगर 2/4 कर दूँ तो half कर दूँ तो okay, fine. Sit down. Why distilled water is used as a control in haze sulfur test? You say? No, behind you. I asked distilled water. I am not using normal water. Why distilled water is used as a control in haze sulfur test? डिस्टिल वाटर में तो इम्प्योरिटीज नहीं है, मुझे भी पता है, सबको पता है. बट व्हाई एम आई यूजिंग इट? टू अंडरस्टैंड व्हाट? टू अंडरस्टैंड इम्प्योरिटीज इन व्हाट? सल्फर. हाउ? डो नोबडी विल स्पीक अराउंड. How sulfur? What will happen if sulfur is having impurities? If sulfur, let's say sulfur is impure. Okay, now I am putting that sulfur on the top of the distilled water. What will happen to the sulfur? Let's say there is impurities in the sulfur. The sulfur is moist. Okay, it already contains some water into it. It is a moist sulfur. Now I have added this sulfur on top of the distilled water. What will happen? Usually what should happen? Should it sink or should it not? It should not. But what will happen? It will sink. Understood? Why? Because the sulfur is moist. Once the sulfur is moist, the surface tension that is having, the distilled water that is having the surface tension, it is not enough to keep the sulfur above. Okay? Sit down. If sulfur precipitates in the distilled water in haze sulfur, what does that indicate? Already covered. Tell. Huh? Bile salts. Yeah. Acha, question? This one. Okay. See, distilled water is there. Let's say distilled water has X amount of surface tension. Okay. This X amount of surface tension is enough to hold the sulfur above the distilled water. Okay. Now the sulfur is containing water into it. Moisture means it has some water into it. It can be 1%, it can be 2%, it can be 3%. Whatever amount of moisture is there, it is moisture. Once a dry particle gets moisture, obviously it will get more, the weight will increase or decrease? Increase. If the weight is increasing, is it enough? The X surface tension is enough to keep it above? No, obviously it will sink. Obviously it will give false result. That is all. Now name the bile salts and their functions. Sodium glycocholate and sodium taurocholate. And what are their functions? That is the test you are talking about. They reduce the surface tension. What is the function? Exactly. Absorption of the fat and. Okay. Now in which disease excess amount of bile salt can be found in the urine? Obstructive jaundice. Why? Regurgitating into the liver, getting into the systemic circulation, coming out in the urine. Fine, lovely. Now, what are the constituents of the Fauci reagent? देख के बता रहे नहीं है, ऐसा नहीं होगा. देख के बता रहे. Ferric chloride and trichloroacetic acid. Okay, that's all. Now, how bilirubin is formed? Breakdown of hemoglobin. Hemoglobin breaks down into heme and globin. Heme converts into biliverdin. Biliverdin converts into bilirubin. Fine, lovely. Now, what is the significance of the negative Ehrlich test? First try to understand. You stand up and then make them understand as well. Say, be bold.
Negative word is
What does that mean? Indicate that Ehrlich test is negative.
the urine doesn't have urobilinogen.
Exactly. Then, what does that indicate? If the urine does not have urobilinogen, which condition can be? The urobilinogen, the bilirubin is not coming into the gut. That is why urobilinogen is absent. If it is not coming, means what? Obstruction is there. Exactly. That is what I was coming into. Okay, with which protein does bilirubin bind for its transportation? Very easy, albumin. And forms what complex? Unconjugated albumin bilirubin complex. Okay. Now, which bile pigment gives the green color in Faucher test? Biliverdin. Biliverdin gives the green color. Okay. Any doubts from the topic? Anybody has any doubt from the topic? एक बार explain करना है. ठीक है. First, try to understand what is entero. Okay. One is entero, one is hepatic, and then circulation. Okay. Break the words. Entero means gut. Okay. Hepatic means liver, and circulation means in between these two the circulation is going on. So this is the stomach we have. Okay, food is coming through the duodenum, then the small intestine. I am not writing the proper small intestine, just small intestine. Okay, now small intestine will meet into large intestine. From here the large intestine comes. This is the appendix and this is the large intestine. This is the ascending. This is the ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and then anal canal. Fine. Now whenever food particle is entering through here, let me use another thing. Whenever food particle is entering from here, it is coming through this way. Okay, it is coming through this way. Up to this much it comes. Okay. Now here is pancreas. Okay, and here is the liver. Okay, now this comes here, this comes here, and this is the gallbladder. Okay, now liver enzymes are coming, bile salts, bile pigments, bilirubin, everything is coming over here, mixing it up here. From the pancreas also the pancreatic enzymes are coming over here. The food bolus that is there, it will get metabolized. It will get all these enzymes and all this bilirubin and all this will help in breaking down the food. Pancreatic enzymes breaks down the protein, fat, everything. Some of it has been already broken down in our mouth, then ultimately comes over here. It is finally broken down and forms micelle. What is micelle? You will get to know in physiology. Micelle is the combination of all these things. Okay, this micelle will come down through here. Ultimately, in the small intestine, throughout the process, it will get absorbed. It is not like ultimately from the terminal only. Throughout the intestine, it will get absorbed. But the highest amount get absorbed from the terminal ileum. Okay. Three parts: duodenum, jejunum, and ileum. Fine. From the terminal ileum, the highest amount of the nutrients gets absorbed. Okay. So over here, the nutrients are getting absorbed from the small veins. Okay, once or the vessels, once it gets absorbed, it will get into the bigger veins, then into much more bigger veins, then ultimately all these tributaries will go and meet into the liver. So from the gut the nutrients are coming, getting reabsorbed and going into the liver. Over there they are getting metabolized because the metabolism is taking place in the liver. From there we are getting the energy, whether it is glucose, whether it is fat, whatever it is. Some fats are getting distributed in the adipose tissues, getting stored in the body. Glucose are getting stored over here as glucose and glycogen. Later on, whenever we need energy, the glucose are getting metabolized, giving us energy. When we are short of glucose, the glycogens are breaking down into smaller particles. We are getting again energy. When glucose, glycogen, nothing is there, the adipose tissues are breaking down, releasing what? Fatty acids. Fatty acids are coming into the circulation. Do what? Again gives us energy and forms ketone bodies. Now remember, the ketone bodies from where the ketone bodies were. So basically this circulation is known as the enterohepatic circulation, through which the food particles are coming over here, getting reabsorbed, and this circulation keeps on going on. Okay, so enterohepatic circulation means the food is coming over here, getting absorbed, going back to liver. That is what the enterohepatic circulation. Any doubts? Okay, fine. Both of it have to be 3/4. The reason is simple. If it is not 3/4, obviously it will sink.
इन सर ऑब्स्ट्रक्शन सर अगर आपका सर इंट्रा मतलब जो आपका दाखिल अंदर अगर सर एक साइड ब्लॉक हो गया तो वो आइडेंटिफाई
थोड़ा बहुत आएगा तब तुम्हारा वो टेस्ट नहीं होगा. दिस इज ए क्लिनिकल कंडीशन. यू विल अंडरस्टैंड द बिलिरुबिन विल बी रेज्ड बट नॉट टू रेज्ड. That you will get to know when you will be studying medicine actually. There are multiple variants because of tumor, because of choledocholithiasis, because of cholelithiasis, multiple variations will be there in the reports. So that you can get when you are studying clinical. Not right now. Right now, for now, just understand that if there is an obstruction, complete obstruction, this will come. If there is no obstruction, some other thing will come.
Thank you, sir.
Yeah. Yeah, this much only. It's floating. See?
Surface tension.
Yeah. Now keep it here. Now if you move it little bit more, then it will sink. Okay? Now do it with this one. अरे उठा लो, इससे भी कम लिया है, डालो.
2/3. Sinking due to the seasoning down.
Add little bit more. Yeah, this much. As soon as you add, it is going down. That's all. It's still floating over there, even though it is not distilled water. Okay, but it's still floating. But over here, just because it contains bile salts, it will reduce the surface tension and it will let it sink. The test is simple actually. The test is nothing so much rocket science in the test, but theoretically you have to know whatever I have said. That you have to understand, that's all. And the examiners can ask you why 3/4 is failed, why you are using the distilled water as a control.
So that it doesn't go down.
Yeah, exactly.
Hepatitis A and B. Hepatitis A.
There are viruses actually, hepatitis A and hepatitis B virus, hepatitis C virus, hepatitis D virus is also there. Because of the viral infection, you can get hepatitis. These viruses will destroy the hepatocytes. And whichever virus is responsible, they will cause this type of hepatitis. Basically, A and E is having fecal-oral route, like means with stool, by the stool, it can spread. And if somebody is having hepatitis and their stool contains hepatitis A and E virus, you mix it, comes up with your mouth, you will get hepatitis. But hepatitis B, C, D is bloodborne completely.
So it is
Sinking. Yeah. No, but that one floating. Okay, that's all. Okay, if you two are done, go back, send 2 more. We will just do the test, and after that I will show you the test again, that Focher test. Over there sir will show, over here I will show again. Okay? It settled immediately, but over here also some settlement you can see. Why? Because of the water. We are not using distilled water, we are using the tap water. That is why some bit of settlement will be there, because the water is not pure. Over here not the problem with the sulfur, over here the water is the problem. Okay, fine. Okay, you people can go. If you have any doubts, you can ask later on.
Okay.
Yeah, or you can ask now as well.
One doubt, in hemolytic jaundice, why is bile salts not present in the
Bile salts are coming in which mechanism? Bile salts are coming in which mechanism? In hemolytic jaundice, bile salt will be present in urine. Normal level, nothing is going to happen with the bile salt. In hemolytic jaundice, the problem is with the RBCs breaking down. Once the RBCs is breaking down, this is forming the bilirubin. The bilirubin will be more in blood, not the bile salt. The bile salt pathway is normal in that case. In hemolytic jaundice, there is nothing to do with the bile salts. In hemolytic, everything is to do with the bile pigments, that is the bilirubin. Okay, but in case of obstruction, then the pathway comes of the bile salt, because it is not being able to come down. Then it will get into circulation more and more and more and more and more. And once it gets more into the circulation, it will come out in the urine. Fine. That is the excess amount of bile salts. And normally some bit of can be there. That is not a pathology. Keep the test. abnormalities in the test as well. What will be the abnormalities? Some bit of sulfur will precipitate, but some will be there on the surface. But if in the urine, just because it contains the bile salt, everything will get precipitated. Fine, do the test. Some particles are there in the urine, that's why it's forming the bubbles.
Roughly 3/4.
Yeah, roughly 3/4. Yeah. How much is pinch? Yeah. Yeah, almost. See the difference? Keep it like this. These two are your samples, right? Now do the test. It's floating, right? Yeah.
Is due to disinfectant action of that.
See?
Sir, should I take more sulfur crystal or is it enough? This is water.
Yeah, this is enough. See over there. Leave it. Fine. If you keep in your hand with the sulfur, obviously your hand is moving. It will everything will settle down. You are understanding? You have to keep somewhere, or else just keep the put the sulfur powder. Immediately you keep it. Because if you keep on moving your hand, obviously everything will get settled down. That is what was mentioned over there in the precaution. Do not shake, do not mix it. If you mix it, everything will settle down eventually. See there one, over there you go and see. Let's take a little bit more. Yeah, fine. Keep it here. Keep it here. Okay. Now add pinch of sulfur in both of it. How much is pinch? Show. Yeah. Add here. Yeah. Let it be. Add over here. See the difference. Now you can see the difference. It's still over there. And it is already there. As soon as you give it, it will fall. हाँ हाँ मैं दिमो
অনেকক্ষণ হয়ে গেছে দিকে না কি তা বলতেছি না বাট
As soon as you give, it falls. Over there, it will not fall immediately. It can fall because of the impurities of the water, but it's slowly. But over here, as soon as you give, it will fall. It contains bile salt. That is what the bile salt is reducing the surface tension of the water. Once the bile salt is reducing the surface tension, it will immediately fall. If it is no, it is, yeah, it is falling. See, it is falling. It is not that it is not falling. It is falling. over there, immediately it will fall. And see the amount, how much it will. See, that is the difference that you have to understand. If it would have been distilled water, then it would have. Is it green? Who can see it green? Let me give me a white background. Is it green? Okay, I'll show you. The background logo. White background. White background. No, see the color. Some bit of greenish tinge, but not exact green. That one was there over there. That was exactly green, but over here, because in the sample it has little bit precipitated down already. So whenever you are doing the test, take the immediate sample. That will give a better